All right, everyone. Thank you all for coming. We're going to go ahead and get started with this lecture on endometriosis. Very grateful for all you guys coming out to watch this and for those attending. Hopefully this lecture will be, so I'll post it to my medical YouTube channel, hopefully by the end of the week. Kind of depends on the recording quality of this video. Otherwise, I might just redo the video at home with PowerPoint. So that will be available, and there are some QR codes for that YouTube channel to share with other people. So, but again, thank you all so much for coming out. Endometriosis was an unintended passion of mine that has just developed over the years, and so grateful to be able to provide care for patients in this area with this diagnosis. Let's just go over the learning objectives that we'll be going over today. So first off, understanding the basics of the menstrual cycle and how that can correlate with endometriosis. Understand common symptoms associated with endometriosis, and then understand why it's commonly missed, and then understand some medical and surgical options that are available for treatment of our patients. Some of the images on here, these are some of the sources where they come from. If there is any patient pictures on here, have obtained consent, and they're also de-identified, if that is a concern of any of the people here or watching. And I don't know if I need to say this or not, but any comments made by me, Dr. Matt Allred, are not the official views of Madison Memorial Hospital and or Madison Women's Clinic. For those who know me well, I have a sick humor, and I need to be careful and watch my tongue today, and I'll try and keep it appropriate. So I always do like to recognize those who have helped me along the way. Of course, I want to recognize my parents who saw something in a skateboarder punk rocker with bleached tips and all frosted tips, and somehow got me to where I am today. Also in residency, Dr. Corey Wagner, he helped me obtain an ear and an eye for endometriosis. And this Dr. Adam Duke, he's in Post Falls, Coeur d'Alene, just an amazing endometriosis surgeon. He's the doc who got me more interested in excisional endometriosis surgery. Then, this is Dr. Jeff Arrington, amazing robotic surgeon down in Utah. Did a little bit of robotic training or watching him with his robotic skills, and absolutely got me motivated to do more robotic endometriosis surgery. Very grateful for Madison Women's Clinic, where I work, for the staffing there. In particular, our ultrasonographers who are here today. Why? Because they are advancing their skills to help me better diagnose endometriosis. They're doing additional training so we can better provide better care for our patients. Of course, this hospital, Madison Health, we have an incredible OR team, and especially the robotic OR team here is just amazing. And what we can provide here at this small little town just is, I'm so grateful for them. Absolutely got to recognize my partner in crime, Dr. Evans. If it weren't for this guy, I would not be here today. I remember I was a med student here, and I was planning on going to pediatrics, of all things. And then by the pharmacy, I'm like, I think I want to do this. And I get out here, I'm like, when I'm finally a doctor and out here with him, he's like, dude, I was joking with you. You're not made for this. I'm like, dude, come on, man. That was real. I went through 4 years of residency, now I'm here. but no, very grateful for him pushing me and helping me advance my skills. And then, of course, those who know this lady right here, Christy Goody, is my nurse. She is the driving force for me. And then, of course, got to point out my family. And yes, these are typical houses. And yes, I might be wearing my Slytherin socks right now for good luck. But all right, well, let's get moving on. So, case presentation. This is Imena Lada Payne. She's a 23-year-old. She hasn't had a kid yet. She's been having issues with significant pain with her periods ever since age 16. This has been gradually getting worse over time. Her pain often has her missing work regularly. She's having to call in sick and just lies fetal position in her bed all day long. Also reports, sorry, there's no presentation for me to look at here. That's not too helpful, so I'm gonna have to turn a bit. She reports that intercourse is very painful for her, to the point where if penetration can actually occur, significantly painful for her, so it's causing some relationship issues. Past therapy, basically over-the-counters, ibuprofen, Tylenol, Midol. She has had, she tried some birth control. Initially it helped, but over time was no longer having any effect. This right here is basically textbook endometriosis. This is it. 99% chance this lady has endometriosis. But let's go over how we can counsel this patient. And yes, these answers that you will see are actual things that my patients have been told. Number one, oh, sweetheart, this is just normal part of being a woman. It's just a period. It's just an ovarian cyst. Anyway, I'm not going to comment too much on that. Grow a pair of ovaries, sister. You're being emotional and dramatic. It's all in your head. And then, this does not sound normal. I wonder if this could be endometriosis. Let's send you to a specialist who can appropriately work you up for these symptoms. Kind of like answer D here. Now, I feel that when we're trying to understand endometriosis, we need to understand the basics of human anatomy. And so I'm going to do that today because I think this is quite a misunderstood aspect of women's health. So I don't know if this pointer is going to work or not, but so we have the vagina, cervix, uterus. We have the endometrial lining. This is the lining that bleeds with period. We have the myometrium, which is the muscle, helps shed off that endometrial lining, but also, of course, the contractile force of pushing baby out. Then the serosa, which is the outer lining. We have the fallopian tubes. These are tubes. Basically, they will help pick up the egg that's in the pelvis to transport it into the uterus. And, of course, the ovaries, which is what produces hormones, estrogen and progesterone, but also releasing eggs. Of all the anatomy on here, the ovaries are the only thing that produce hormones. Very commonly have women worried about a hysterectomy, that they're going to lose all their hormones. As long as we leave those ovaries in place, they will still have hormones. Now, ovulation. Very important to understand the basics of ovulation. So we have hormones from our brain, luteinizing hormone and follicle-stimulating hormone that will cause certain effects on the ovaries. First, we'll see little eggs that will mature into follicles. Those follicles will gradually grow and grow and grow, form some cystic material in them, to the point of becoming an ovarian cyst. I know that's a trigger word for a lot of women, understandably so, because you hear about the bad and the ugly more often than you hear about the absolutely normal functional cysts that are on almost, of the women in this room, I would say 99.9% of you have a cyst on your ovary right now as we are speaking. Why? You cannot ovulate unless you have a cyst on your ovary. So that is one of the most misunderstood, and I'm hoping you guys can now dispel that information that, yes, ovarian cysts are normal the majority of the time. Not always normal, but in order to ovulate, you need to have a cyst on your ovary. What's kind of interesting is that the fluid in those cysts, I kind of picture those as like a medium for that egg to just float around in, and those fallopian tubes act as little drains to kind of just suck up that fluid, and that egg just kind of tags along. Kind of a little bit of a visual of that. Now, what's also interesting is that this cyst will then help produce progesterone, which is going to be very important for the endometrial lining. I find this very interesting picture of surgery I did recently where this patient, she was about to ovulate from this ovarian cyst. I didn't want to watch, I didn't wait too long in the surgery, but she very well could have ovulated from this within a day of this picture. Now let's understand the endometrium. So the endometrium is the lining, the most inner lining of your uterus. And in response to estrogen, especially spikes of estrogen, we're going to see it thicken. In response to progesterone, which is coming from your ovaries, we're going to see stabilization. We can use this knowledge to our advantage of maybe not having as heavy periods if we were to start higher dose progesterones maybe earlier on, so we don't see that growth. Having a stable estrogen progesterone can be very beneficial when we're looking at birth control, when we're looking at endometriosis as well too. All right, so going over the histology, endometriosis is basically the presence of endometrial glands or stroma outside of the uterine cavity. One thing that is often a misconception is that adenomyosis is endometriosis. No, that's in the muscle of the uterus. And then endometriosis typically implants on what's called the peritoneum, which is a membrane that basically lines the abdomen and pelvis. So parietal is more on the wall, so to speak, whereas visceral is more covering the pelvic organs. So here's a demonstration of what endometriosis work could be. So on the tubes on the outside of the ovary, on the outside of the uterus, or kind of on the ligaments. And then this is a picture of adenomyosis where we're seeing it more invading the muscle. Now, as for the histology, there's superficial endometriosis, which I feel is more common. It's not too invasive, not going too deep into that peritoneum, but it definitely causes a lot of inflammatory changes to the surrounding tissue. And what's interesting about that inflammation is oftentimes the pathology report may not come back showing both glandular and stromal components, which sometimes, well, I'll discuss this later when we're talking about actual pathology, but sometimes can be a little bit of a diagnostic challenge when we're getting the actual pathology or biopsies. Then there's deep endometriosis, which is when it's over 5 millimeters deep. And then endometrioma is when we see implants of endometriosis on the ovaries. They can be really small or they can be big. All right, so understanding how many women have this, it's pretty crazy to think that up to 10% of women have endometriosis. That's significant. And in America, estimated maybe around 7 million. 30 to 80% will be experiencing pelvic pain, 25 to 50 with fertility issues. What I find very interesting is the last two here, the asymptomatic. So the asymptomatic, so for example, Dr. Evans and I will be operating on someone and for something completely unrelated to any of the symptoms of endometriosis, and we'll find it in the pelvis. There was a hysterectomy we were doing a month or two ago where it took us an hour to finally get to the hysterectomy portion of the case because we were taking down so much adhesions from this patient having endometriosis. She had 6 kids. I don't know if I'm just saying 6 kids. I don't know if she did. I mean, it's Idaho. But sorry. There's my comedy right there. Anyway, but she had no fertility issues, we should say. No pain issues, nothing. And so, but it took us that long to actually just get to the actual surgery of the hysterectomy. The unfortunate part here is the average age of diagnosis, 25 to 30, and even more unfortunate, the amount of time that could lapse in that, looking for someone to finally give you that diagnosis, 7 to 10 years. Next up, here's all the sciencey stuff that smart people have learned about it. I'm gonna do this instead and refer to Marvel Loki, for those who are fans of Marvel. Understanding what endometriosis is, I like to call it a variant of endometrial-like tissue. So that means it's similar, but it's not going to behave exactly like endometrial tissue. It's a variant. I don't know if there's a multiverse of endometriosis, but I'll discover it one day if I can. So, moving on. So how does it actually develop? And it's very, very interesting, crazy disease. One that's kind of been the longest belief of what it is what's called retrograde menstruation. I don't know why, but I don't think this finally clicked one day, I want to say a few months ago. I don't know why it's taken me this long, but I'm operating on someone, she's on her period, and I see blood in her pelvis. I'm just like, where'd this come from? And then realize, yeah, actually I saw this a few weeks ago, So retrograde menstruation, when we think of menstruation, when we talk about menstruation, we think of blood leaving out the cervix, going out the vagina. But remember, there are tubes going into the pelvis. So you actually, on your period, 90% of you, well, maybe there are some in the room, so never, 84% of you will menstruate out your tubes into your pelvis. So it's called retrograde menstruation. Kind of an interesting thing here. So here's a little picture, kind of wide out here, but down here is basically some menstrual blood during this patient's surgery. And what's interesting, we'll commonly see endometriosis implants more in the dependent areas of the pelvis there. And then other theories of what's called lymphatic or vascular spread, where we can see endometriosis in the central nervous system or in the lungs. And then finally something called coelomic metaplasia, which is pretty weird, where we have endometriosis where it just simply shouldn't be. So in prepubertal girls who haven't even had exposure to estrogen, and at least in the last thing I read, 20 case studies of men with endometriosis. So weird, very weird. As for staging, I'm not going to go too deep into this, but the main thing to understand about staging is that it doesn't necessarily relate to what we typically consider staging as a severity of something. It's more for basically discussing the location, the amount, the depth. But when it comes to severity of pain, fertility potential, really it doesn't really correlate well. So here's a few of the staging systems that are used. ASRM is kind of more commonly used there. But this is what I tell every single one of my patients when they wake up from surgery and they're saying, so how bad is it? What stage am I? And I tell this before surgery as well too, but here's the deal. The amount, the size, the location, the depth do not correlate with your symptoms of pain and your lifestyle, how this is affecting your life. There's not a direct correlation. As I mentioned earlier, our hysterectomy from a few months ago, who had none of these symptoms but had it everywhere, versus my patients who are crippled by their endometriosis, and I find 4 little freckle-sized spots, remove it, and they're saying, wow, my post-op pain is better than any pain I've ever experienced in my life. I mean, they've just been stabbed a few times, and they have gas, up against their diaphragm, and they're like, this feels so good, and it's just amazing how that can really affect people. So I did quote myself there. I'm not that inflated, but I felt like quoting myself. One day it might make it into a book. And so anyway, so risk factors. Family history, 6 to 7 times higher risk of having endometriosis if you have a first-degree relative. Increased exposure to exogenous estrogen or endogenous estrogen, basically what you make. And then increased flow or intensity amount of blood that women may have. Decreased risk factor is kind of the opposite of what I just mentioned there. So how does this impact women? So if we look at the financial disparities that can happen here, there's when it takes 7 to 10 years to get that diagnosis, that's a lot of visits to healthcare practitioners. That's for those that need reproductive assistance, infertility specialists, definitely quite expensive. Also considering the medical and the surgical treatment involved as well too. Mentally, this is taxing. It's very difficult, especially for those with infertility, those with that social stigma of, oh, this is all in your head, all those options that I showed at the beginning of this presentation on, well, sweetie, it's just your ovaries, it's just your hormones. There's that belief of, really, so is it just in my head? And what's interesting is the pain can amplify mental health issues. Mental health issues can amplify the pain. And then, of course, with relationship issues, there's so many women who can't even have sex. That's a very important part of relationship. Oh, my mom's listening. Love you, Mom. That's how we had grandkids. And that's the only time. But anyway, so clinical presentation. 2 words that best describe endometriosis: pain and inflammation. That's how I best describe endometriosis, that really quickly there. So number 1, dysmenorrhea or pain with periods. Now, a period is an inflammatory state, and it's not going to be comfortable for anyone, for any woman. But in endometriosis patient, this is quite heightened. This is moderate to severe. This is missing work. This is functionality decreased. Most commonly, if I see a patient whose functionality is decreased by about 50% or less, almost 90% right there with just what I've just said, chance of seeing endometriosis in surgery. And very commonly do I see this pain worsen over time. So many of you have experienced that right there. Next up, chronic pelvic pain. So non-menstrual pelvic pain, which just basically means you're not on your period, but you're still experiencing pelvic pain. And this is often presenting with, oops, I went too far there, with increasing pain noted around time of ovulation, or increasing pain typically seen the week before a period. Those are kind of the most common times when you'll notice that pain. Next, dyspareunia or pain with sexual intercourse, intimacy, or stimulation. This pain often happens either with entry, during, and lingering pain afterwards. There is one condition I regularly see with endometriosis called vaginismus, which is basically just involuntary contraction and tightening of that vaginal smooth muscle and pelvic floor. Then biggest complaint as well too is deep penetrative pain with intercourse. Climax may actually trigger pain in some women, and pain may decrease their ability to climax. For those that are not sexually active, one common question I ask is, well, can you actually place a tampon when there's, if they still have a hymenal remnant, maybe they can't for that reason, but if they just simply can't place a tampon because of the pain or the excessive pain with removal of that tampon, that can give us an idea if they could have this in the future. All right. I want to rewind here. Okay. Now I need to talk about pelvic pain. So I need you all to understand pelvic pain with a very easy life situation that we've all probably been in. When my wife and I go on a vacation, it is called a vacation. When we go on a vacation with our kids, it is now a trip. There's a big, that's just how it is. Why? We want our trips to be vacations and look like this, where they're all happy and, not feral, I don't know, but instead we have the kid who's hungry, the kid who's angry, the kid who's tired, the kid who wants to bother everyone else. There's that conflict. And so we often look at the pelvic pain, and we can somewhat be a little bit, we don't quite look at the whole picture here. And so very commonly with my patients with endometriosis, we need to have more of a look at everything else. So looking at the bowel symptoms. So very commonly do I see women with endometriosis have irritable bowel syndrome, ulcerative colitis. So we need to look into, are they having change of bowel habits? Bloating is a huge issue. We often see diarrhea and constipation really start flaring up around the time of their period. Nausea, vomiting, pain with bowel movements. Urinary symptoms. A disease I very commonly treat is called interstitial cystitis or painful bladder syndrome. If you were to imagine micro canker sores inside your bladder, it kind of gives a good idea of why there's pain when your bladder's full, and that pain persists for a few minutes afterwards. You're having to get up multiple times, go through the bathroom all day long, and getting up multiple times at night. So very commonly see those together. And then even blood and urine. And I always want to point out that these symptoms typically worsen around the time of menses. This is all the possible differential well, not all of them. This is a few differential diagnoses on all the pains that could be associated, all the diagnoses associated with pelvic pain. I'm not going to read through these, but it's vast, and that means when we're looking at pelvic pain, we need to have a multi-system approach. We need to involve a lot of different subspecialties and specialties, which I'm so appreciative of the expertise here in this area as well too, that I regularly refer to. I wish I could spend more time on infertility. I'm going to address it a little bit, but infertility is the inability to conceive within 1 year of trying with having regular sexual intercourse without birth control. Prevalence, about 25 to 50% with those with endometriosis have infertility, and vice versa. The mechanism is a bit unclear. So one suggestion is distorted tubal anatomy, and this is definitely more so when we have scar tissue or adhesions kinking those fallopian tubes. Another theory is altered peritoneal function. So we just have this inflammatory environment for that ovary to ovulate into, and that egg is just in this inflammatory, its environment is inflammatory, and so we can see interference with embryogenesis and then reduced endometrial receptivity. The hard part about infertility is that when we look into medication management for this, it's kind of the opposite of helping you get pregnant. Why? Birth control hormones basically are suppressants to ovulation, to endometrial proliferation, for tubal motility. So improving improving fertility with these mechanisms isn't too common, but preserving fertility yes, that can be helpful for those not yet seeking pregnancy but wanting to maintain fertility. So, I absolutely believe that birth control, the correct birth control, is definitely important for preserving fertility in patients not yet ready to get pregnant. Now, surgery for fertility issues with endometriosis may improve fertility, and there is, of course, always limited data on this. For stage 1 to 2 endometriosis, it is suggested that in order to actually have someone benefit from the surgery to get pregnant, the number needed to treat, so NNT, is 12 women. So after 12 surgeries, one of those women will actually have needed it to get pregnant. The others, really, did they need it or not? It's a hard question. Now, for more severe cases, stages of endometriosis, when there's an endometrioma, those endometriosis implants or cysts on the ovaries, you need to take those out. That's going to be very important for fertility. One study suggests that sometimes you might just want to move right on to assisted reproductive technology versus considering surgery. That's definitely debatable, but that's why it's important to have early referral to reproductive endocrinologists and fertility specialists. All right, evaluation and diagnosis. The hard part about evaluation and diagnosis is there's limited efficacy, not always going to find something. So on physical exam, very commonly we will see pelvic floor tension. It's an inflammatory state, just as if a muscle were strained, we can see that pelvic floor tension. Uterosacral ligament, tenderness, tender points, and then presence of the pelvic mass even, that's pretty rare to feel. Unfortunately, there's really no laboratory workup that can be beneficial for endometriosis. I do get labs on my patients with concern for endometriosis to rule out other pathology, but there's really no lab that's going to confirm or rule out endometriosis. There is one lab that is elevated with endometriosis called CA125, but there are several other diseases that this is also limited. So really there's not much of a benefit. It's basically just wasted money to draw these labs and follow them. Next, imaging studies. Transvaginal ultrasound is by far one of the more likely ways to at least assist with diagnosis to give that clinical suspicion. And now I say that carefully because when we're looking at endometriosis implants, sometimes these are about the size of a freckle or a mole. And so an ultrasound is really not going to pick those up too well. Now, when it's more advanced, bigger, deeper lesions, but especially endometriomas, yeah, those are pretty easy to pick up on ultrasound. Rectosigmoid implants, usually those are going to be a little more developed and light up a little more on the ultrasound. So again, I like to thank my ultrasonographers again because they have very appreciative of them furthering their techniques and knowledge on this because it can be very helpful with planning surgery of knowing, wow, might be a pretty severe case. And we're doing basically real-time imaging to look into some of the reaction of endometriosis in that pelvis, and I'll show some ultrasound imaging pretty soon here. But also need to look at the whole spectrum, very helpful with ultrasound to actually see other pathology associated with the uterus and ovaries and tubes. Transabdominal ultrasound is performed on women who may not be able to tolerate a transvaginal ultrasound, but they're quite limited, very difficult to see any endometriosis. As for some imaging study, this is a uterus, and I'll kind of outline it here. So uterus. And what's interesting about this uterus is that we have initial anteversion, but then retroversion right here. And so I'll draw that right there. So this could be suggestive that there could be scar tissue right back here. Why? Because we see that uterus just kind of be pasted to that posterior pelvic wall there. Hopefully this will work. So this is called the sliding sign. So the sliding sign is basically when we're pushing on that cervix to basically hope to see some good displacement of that uterus. So if this is the pelvic floor, this is the uterus, we want to see this movement where they're not connected, not that movement where they connect. And we see that tension there. So hopefully this will work. Yay. Cool. So with this one, and again, we're going to see that, that's probably, come on, work for me. Yeah, I figured that would. So right here, we're seeing good movement of that uterus on that pelvic wall there. Whereas with this one, you'll see already just a kind of defined white line right here. So this is going to be where we're going to see adhesions or suggestion of adhesive disease. Oh, come on. I knew this would happen. Come on. No. Let me try that one more time. Yes, look at that. Cool. So we will see not as much movement when we're pushing on that cervix there, not that much movement of that uterus. All right, and then this is an endometrioma. So what's interesting about endometriomas, especially when they get big like this, is that we have implants on the ovary, and ovaries are insane. They can just grow and grow and grow and grow, and those far and few between horrible cysts that definitely make the news, so to speak, these are in that category where it's crazy those ovaries can just fill and fill and fill over time. We have fresh blood of that endometriosis bleeding into these ovarian cysts, but they have nowhere to go because they're just stuck there, and they will kind of dissolve and turn into, well, not completely dissolve, they'll turn into this chocolatey syrup-like material. So for those who like Hershey chocolate syrup, that's what it looks like. Anyway, so here's another good visualization of those endometriomas. All right, imaging study, MRIs. I have not ordered one yet, but with more crazy appearing ultrasound findings, where we might need to consider sending someone more to a university setting. This is where, if we need to get gynecologists involved, we have to have general surgery in the room as well. When there's that, that's about the time when we need to consider MRIs. All right, so diagnosis. Surgery is the only way to diagnose endometriosis. We can have a very high clinical suspicion for endometriosis, but the only way to truly diagnose it is surgery. This is one very important thing to understand is surgery does not cure endometriosis. I want to make sure that's clear. It's the unfortunate truth of it. No matter how much we find and remove, we're not going to see the microscopic level that will eventually grow over time. So multiple surgeries are often needed in women's life. Pathology identification is considered the gold standard of diagnosis. That means cut out a piece of endometriosis, send it to the pathologist, and they're going to look at it and say, yeah, hey, look at these endometrial glands and stroma. Oftentimes we'll see fibrovascular changes or these hemosiderin-laden macrophages are kind of the more common things that they will describe. But there's definitely a lot of different colored lesions depending on how long they've had the disease, where the inflammation is, sometimes where they are in their period. Allen-Masters windows, I'll show a picture of that later, but if we think of those dependent areas of the pelvis, and we almost think of erosion of that pelvic floor due to endometriosis, that's what those look like, and then of course endometriomas. So can you spot the endometriosis here? So, if you guys want to use your imagination and see, okay, where could the endometriosis be? And yeah, cool, hopefully you guys saw that, but you might have missed those. There's a lot of little spots that are often missed with this. This is a little bit more easier to see, but this picture is actually pretty amazing because it shows multiple stages of endometriosis. So very commonly we see like this neovascularization, so a lot more blood flow to a certain area. These hemorrhagic powder burns, then these clear vesicular lesions are definitely more of that new inflammatory state where we see white fibrotic lesions, which is going to be more in that, where we see more of a result of scar tissue from maybe more prolonged endometriosis in those areas. Then, here's another image. So this is the uterus right here. This is the bladder up here. And this woman's likely near her period. Why? Just a lot more injected red vessels. Also, we see that those endometriosis implants a little bit more robust looking there. And this is after, and that's kind of the extent of where that endometriosis could be on this patient. And this is the picture after excision of that tissue there. And, This is what an endometrioma looks like, again, on ultrasound, but then in the OR, basically that's that chocolatey Hershey syrup coming out of the ovary there. Now imagine if that were to rupture inside someone's pelvis, not during surgery. Talk about inflammation and pain. I mean, this is like, exploded appendix-like pain that these patients can experience. Is this still working okay? Cool. All right. Then this is an Allen Masters window, that erosion, so to speak, of that pelvic floor there. So why is it missed? And I cautiously approach these next few slides because it's very easy to point fingers, and there's just so much involved when it comes to health, when it comes to diagnoses. So I cautiously approach this. And our goal from this lecture is basically to make that catching a lot quicker. And so women with endometriosis often express being unheard, ignored, and overlooked. Very common, very common. Historically, it's kind of called the missed diagnosis. About 7 to 10 years, again, of trying to find someone who's going to figure it out. Historically, back in the 1980s, it was a rare disease back then, considered a rare disease. So definitely that normalization of this significant pain that was altering their lives and causing a lot of issues with fertility. Misdiagnoses. Again, everyone has their specific field of medicine, and so it's more likely that you're going to be focused on your field of medicine. So naturally, a gastroenterologist is going to look into irritable bowel issues, spine or orthopedic. A doc's going to look into more, well, could this be bones or something? So there's just so many different fields of medicine. So it's not uncommon to have other diagnoses when there's that concern for endometriosis. Gender pain gap. Hear me out. Women are hormonal. Now, let's refer back several slides, don't attack. But remember, your luteinizing hormone, follicle stimulating hormone do this. Your estrogen does this, and then it does that. Your progesterone does this. So if I were to check your hormones today, 3 days from now, 5 days from now, 2 weeks from now, they will not be the same on all those. So if the definition of hormonal is regularly changing hormones, you are all hormonal, okay? Whereas guys were just like, so anyway. Yeah, I'm not going to say it. Okay, cool. Done. Yeah, I know. I have so many things I want to say right now, but this is, moving on. Okay, good. Good job. I did it, Ed. I did not say what I was going to usually say here. Okay, talk to me afterwards now. All right, so government funding. So back in 2017, there was only about $6 million going towards funding of endometriosis. So we're talking about, of the 288 diseases included with funding and research, it was ranked 279. Very happy to see in the last 2 years and projected in 2025, now up to $29 to $30 million going towards research and advancement of understanding with endometriosis. Access to healthcare is very difficult, especially, we're in Idaho, there's a lot of rural towns here, and so, availability of surgeons, specialists with this is not too common. As already described, the inconsistency with workup. We're getting ultrasounds in the lab saying, hey, sorry, you don't have endometriosis, nothing's showing up. It's just like, wait a second. No, you can't say that because, again, they're not the highest of yield. Now, there's also some things that may delay the diagnosis, whether it be some certain parenting and guardian types. And I can relate to a few of these as a parent. Authoritarian, I'm kind of more like that with my kids. I'm like, sorry, grow up. But I should not do that. Neglectful, sometimes I'm uninvolved, well, when I'm playing Nintendo, yeah. Single parents, I mean, it's a hard life for the parents to be raising kids and doing all they need to do. Abusive parents, financially strained, and those who maybe more seek alternative medical therapies. But also patients, and some of these characteristics, these personalities develop over time with this disease. So it's not like one precedes the other all the time, but those who are people pleasers who just don't want to cause issues. I don't want to bother you with this. Those that are introverts, those have very high pain tolerance who are stoic, and then white coat syndrome, just not wanting to seek medical care. All right, So I'm breaking for a random question. Can anyone here in this room recite the quadratic formula? Nice. Yeah, at least I knew Sonia would. And so, I would say, you've all learned this in junior high, so why can't you recall this now, guys? And it's easy. X is equal to the opposite of b plus or minus the square root of b squared minus 4ac all over 2a. That's the quadratic formula. Why would I say something like this? Come on, you guys all learned this in junior high. And so this is why I'm saying, hey, we need to give clinicians a slight break, but yes, we still need to, give that whole aspect of understand in med school, I always appreciate when people are like, hey, I got this question about this rash I have. I'm like, dude, that was a 20-minute lecture 10 years ago. I don't know what you have, and you're a dude. I don't know. I know certain parts about women, and that's about it. But so a lot of the exposure that we get in our clinical training, in our professional postgraduate training, we're talking about a 30-minute lecture and maybe some exposure later on in our training. And so that's one thing that I always want to point out is nope, all my lectures on nephrology and neurology have been replaced by 21 Pilot and NF lyrics and Harry Potter, and so they're gone, and that's just how it is. Now, also the time involved with assessing patients. There's some days where I have 4 patients an hour. There's some days when I have 10 patients an hour. And the time it takes to properly assess someone with these symptoms, when you're looking at everything else as well too, it's limited. If I were to sit down, and this was my issue probably about 5 years ago, when I sat down with my patients to kind of see if they had endometriosis, I liked to ask the questions, I wanted to listen, but the problem is that took 30 to 40 minutes, and when I have 4 patients in an hour, turns out I get behind, and then I get behind, and then I get behind. And so that's definitely a conflict that a lot of patients have when it comes to clinicians have when it comes to assessing pain, is the time it takes. Then also a lot of the patients with endometriosis are seeking more urgent or emergent care, and those settings are even more difficult to assess pain or assess the origin of pain. It's more of a, hey, let's treat the pain. Oftentimes there will be some imaging performed and they'll find a cyst on the ovary and say, hey, this is your cyst. Wait, let's go back to what we said earlier. A cyst on an ovary, majority of the time, is a normal thing. And so it's important to say, okay, well, where are you on your cycle? If you had your period 2 weeks ago, then having a cyst that's up to, and what's interesting is that a normal functional cyst on an ovary that could ovulate is sometimes between 2 to 3 centimeters in size. That's almost the exact size of an ovary prior to getting a cyst on it. Also, some clinicians have the tendency to say, hey, you should probably go to this specialty or that specialty, kind of redirecting and referring. I like this picture of all the Spider-Mans saying who to go to. Very well. So to assist my ability to just get to the point and kind of get through that bottleneck of understanding endometriosis, I made what's called the Endometriosis Pelvic Pain Questionnaire. I found myself asking the exact same questions every single day, multiple times a day. And there are QR codes throughout the room that you can scan that will link to our website, Madison Women's Clinic, to download those, to send to friends who have those concerns. But it's a very thorough questionnaire that takes some time to fill out. But when I read through this questionnaire, it's like reading the Matrix. And it's sad. It's not sad, it's actually really cool. I can diagnose endometriosis in a matter of 10 to 20 seconds based off this questionnaire now. And I'm not joking. I mean, seriously, it's like, yep, done. You got it. Or you have an 80% chance, 90%, 95% chance. And it's been very interesting to see how much this has been helpful with that diagnosis. Now we're going to treatment options. And I like to use remote buttons. I like to use analogies. And I like to use the movie of endometriosis. You start off at the cabin by the lake, everything's beautiful, and then all of a sudden you find yourself being chased by a bad guy and then attacked by the bad guy. That's endometriosis right there. So our goal is to maybe have this movie not be such a horror film. But the problem is that movie will always play, and so we're going to talk about treatment here. Now, before we go into why did that not show? Okay, yes, no, it is not this one yet. Okay, cool. So lifestyle modifications, diet, exercise. as I said previously, there's often other factors involved with pelvic pain, but anti-inflammatory diets, one that I find really helpful is called Endo-Resolved, very helpful for your bowel issues, but as well as endometriosis. Pelvic floor physical therapy, I'm so grateful for the advanced pelvic floor physical therapists here in this town that I refer multiple patients a day to. What they do for our patients with pelvic pain is just absolutely amazing. Sacral inhibition, something I teach my patients. I have a medical YouTube channel. It's the only video I post on it so far. I've just been too busy with other things to keep posting videos on my YouTube channel, but over the next few years. But this is the current one that is on there, the technique of sacral inhibition. And then there are patches, like the Jovi and Lydia patches. Basically, the theory behind these is just a distraction of the pain, so to speak. Then, over-the-counter medications, non-steroidal anti-inflammatories are typically going to be the best for endometriosis. So it's an inflammatory state, therefore anti-inflammatories can be helpful for that. And a lot of women just aren't properly dosing these. Now, there might be certain conditions, medical conditions, where you want to avoid this much of a non-steroidal anti-inflammatory, but for those who don't have contraindications, these are appropriate dosing for that amount of time. Yes, okay, this is one. So next we're going to get into more effective treatment options, but it involves hormones. It involves birth control, and I hear this on a daily basis. Well, my friend's sister had a so-and-so who had this issue with this birth control, or I had this issue. And yes, absolutely, I agree. I've heard, absolutely agree that yes, everyone can have issues with birth control. But I also like to compare birth control to dating. Which one of these guys is the same? You know, is every guy the same? No, we're not all monsters. Some of us are good. But, you know, the thing is, guys can be good, but they all have certain qualities. And so technically I'm a matchmaker with finding the right birth control for you. It takes some time, and you got to go on a few dates. May not work out, but, you know, just give it some time, I promise. It'll get better. But I like to use that analogy because, yes, not every birth control is going to work, and we really do need to target that. The other thing I want to point out about birth control is we have systemic acting birth control, and then we have local birth control. So if systemic means it's basically going to be going throughout your whole body. So typically we're going to see that with the pills, with the shot, with the implant, whereas with localized, like the IUDs or the ring, that's going to be a lot more local there next to the uterus, but we're not going to be seeing as much systemic. Yes, there will be to a degree of some systemic spread, but there is definitely a difference with how patients may respond to those. So estrogen and progesterone containing birth control, so there's the pills, the patch, the ring, and in some patients we can regulate cycles with these, especially if they have other reasons why their periods aren't regular. But we're maintaining a steady and a constant estrogen and progesterone levels. We're preventing the spike of estrogen, and we're starting a higher dose progesterone earlier on, so your body's not going to be really doing those spikes, and we can stabilize endometrial lining a little bit better. Another option is, okay, well, instead of having 12 to 13 periods in a year, which is kind of the typical, if we were to do continuous dosing, which means let's skip the placebo, let's skip that withdrawal bleed that you have, and do more this continuous dosing, well, then we can decrease the frequency of periods maybe to 4 to 6 times a year. Next is systemic progesterone. So progesterone basically inhibits the effect of estrogen on the endometrial lining, so we kind of prevent the thickening of that tissue. Some of the more common pills for that, medroxyprogesterone acetate, it's kind of the mini pill. It's not my favorite. My new favorite, and I'm not sponsored by them, but Slind, if you guys didn't know what the birth control pills, patch and ring look like, then here's Slind, which is a progesterone only. I'm finding a lot more patients tolerating this very well. Then there's the high-dose systemic birth controls, such as the Depo-Provera shot or the Nexplanon. They're not my favorite, I'll be completely honest. Why? High dose and systemic, so we see a lot more issues with other systems. So worsening of depression and anxiety, definitely. Weight gain, you see that a lot more as well too. So I don't particularly like these for endometriosis. Don't really need to worry about it. It's like, cool. So now hormonal IUDs. I'm biased, but this is where I see a lot of patients do very well with when they are appropriate. And I'll go a little bit more into this. So, but we're talking about a high-dose local progesterone inside the endometrial cavity, which means not as much systemic, but more localized. So what we're doing is we're calming down the periods, we're calming down the endometrial thickness so it's not as thick as it could be. Periods aren't as heavy. But what's really nice is we also have local spread of the of that progesterone to the surrounding pelvic endometriosis implants. So that's very helpful. Here's some of the IUDs available here in the United States. What I do like to point out is the width of these, and we'll go into this in just a second, but my two favorites, and again, I'm biased, I'm not sponsored by these companies, would be the Mirena and the Kyleena. They are my favorites for endometriosis. Now, before placing an IUD, I think there should be a better workup. I think healthcare is lacking in the workup prior to an IUD. Our office, we're a little bit different. We are a little bit, some would consider excessive, but I don't know, placing a $1,300 device in someone blindly does not seem like a good idea to me. So we actually do either ultrasound guided placement or a pre-placement ultrasound. Why is that? We want to measure one thing that I call the functional endometrial width. So that space, that cavity where that IUD is going to go, let's make sure that it will fit. Kind of an important idea. What if there's a cavity defect or septum or some abnormality of the uterus? That's a very important thing to know ahead of time. This is my own data based off our patients, but the average pre-pregnancy, so those who've not delivered a kid, width of that functional endometrium is about 22 to 34 millimeters. The average post-pregnancy cavity width is rarely below the 30 to 32. So looking at the IUD widths, that's very important to kind of see which one would go well there. The other thing too is that very regularly, I have patients like, that was it. That IUD placement was not difficult. Why? Because we have an ultrasound showing the direction and curve of the uterus. So I can know if I tilt the speculum this way, grab the cervix this way, I can more easily direct that IUD so it's not scraping that endometrial lining and causing pain and discomfort. And number one, I'd rather have an IUD placed where it should be. And so we have an ultrasound saying, yep, it's where it needs to be. And I also very much appreciate patients coming in to have it checked later because I wish I could say every IUD I've placed has gone perfectly. I know they're placed where they need to be, but do they, 4 weeks, 6 weeks later, are they still working? Are they still where they need to be? In a few cases, that is not the case. So just showing the difference here. So when you get an ultrasound, what they call the width is going to be typically this part, but that functional width is going to be more that red line right there where that IUD, we need to know that length, that width right there. So I was thinking, let me just show a good example of this. Here is a plastic toy uterus. And here are the pieces. We need to put the triangle in the uterus. If we use the big one, doesn't look like it fits, but what if we just shove it in there nice and, let's just jam it in there. It might fit, but is it comfortable? Probably not. So let's use the smaller one. So again, those who've not had a kid yet might do better with the Kyleena. Now for those who've had a kid, well, it turns out that if we use too small of an IUD, like the Skyla or the Kyleena in these patients, maybe more of a chance of displacement, expulsion of that IUD. So using one more like the Mirena or the Liletta would be more appropriate in these patients. Now, as for the non-hormonal IUD, I actually strongly discourage these IUDs, especially in patients with endometriosis. Why is that? Easy. What is their function? What do they do? So they disrupt sperm mobility and viability. And let's read what it says, causing a localized cytotoxic inflammatory response. But it's not hormonal, so yeah, but it's like, wait, if it's doing that to sperm, does it do that to the endometrial lining? Of course it does. And so that's why so many women who get the Paragard IUD with endometriosis typically have worsening pain because of that. They're also a little more of the wider IUDs, and so for those who've not had a kid yet, even more discourage these IUDs. We'll see if the company comes after me. I hope I'm alive soon, but how dare I say something that I find clinically relevant and true. So I'm sorry, I personally hate these IUDs. And again, I don't want to discourage this, but this is called an IUD where it should not be. Misplaced, embedded, down in the cervix, so not where it should be there. And okay, moving on, I realize I'm running a little bit out of time, so GnRH medications, so the theory behind GnRH medications, if estrogen causes endometrial, therefore endometriosis growth, what if we decrease your body's estrogen to the point where it's like in a pseudomenopausal state? That's the theory behind these medications. So there's Orilissa, which is a new one that's been out for about 7-8 years now. Depends on the dosage of these, but it's kind of a punch card. You can't use these past a certain date because of the permanent effects of these. But very commonly, you are going to experience menopausal-like symptoms on these. Personally, I reserve these for patients who've been diagnosed with endometriosis or maybe just want to hold out a little bit longer prior to having another surgery. I don't like these medications within 2 to 3 months of surgery typically. Why? Because I want the endometriosis implants to be very easily visible. I hate comparing something to chemotherapy, but these are kind of like the chemotherapies of endometriosis, so to speak. They're going to decrease the bulk of that disease. I don't like Depo-Lupron. Way too many patients who, they hated it. It was horrible because what's interesting is Orilissa is an antagonist, so it kind of prevents it, whereas an agonist ramps it up so much that that first month on it is just, it's horrible. And then eventually it's so much that your body just shuts it off. And so it is weird how an agonist can eventually shut it off. But with Depo-Lupron, we definitely need to worry about bone density as well too. And then, not going to even mention these therapies, hardly anyone does these. And then interesting new studies, I hope this will become a reality soon, but most likely it won't. But GLP medications, so the semaglutides, Ozempic, Mounjaro medications, used typically for diabetes, weight loss. These medications do help reduce the expression of certain pro-inflammatory markers in the peritoneal fluid with endometriosis patients. And so when we think about that retrograde menstruation, it can eliminate some of those endometrial cells in that area. So very cool. I don't know if it's going to happen, but one day. Now, this is my favorite part of the surgery. When I'm operating, it's just like a wonderful, wonderful day. I like operating. So let's talk about surgery for endometriosis. So this is typically laparoscopic removal or destruction of endometriosis. Historically, so this is when I was in training, it was considered, so there's excision, which means removal of the implants, or fulguration, which is destruction. They were considered equal in efficacy. The current trend, and I absolutely agree with this, is excision is the current trend. I'll show why later. Cool thing is, and this is why they were considered equal, a year out, about 90% had continued pain relief. Also, it's very important after surgery to move on to some form of suppression, medical treatment for pain relief, but also prolonging that recurrence. Going back to my analogy of videos, we've rewound the video. Let's have it play back at a slower pace. Let's have a triple, quadruple slow motion or a pause while we're back at the beautiful cabin by the lake. So that's why starting some type of hormonal suppression. So typically my preference is to move on to the IUDs in these patients. But if they can't tolerate those or if it's not an option, there's some of the others. Or pregnancy and prolonged lactation. Now, for those wondering, pregnancy should not be a form of a form of endometriosis suppression. Make sure you actually want a kid. Life does not get easier with a kid. Nothing gets better with a kid. Other than, what is it? Why do we have, they provide fulfillment. Yes, that's what kids do. That's what I'm talking. Anyway, moving on. Okay, so and also better outcomes with surgery with those that are more specialist, subspecialists with endometriosis. Endometriomas, so when we have those chocolate cysts on ovaries, medication management is not going to do anything for it. It's unsuccessful. So surgery is really the only way to help with endometriomas. Now, there's a difference. So there's cystectomy, which means removal of those endometriomas, and there's aspiration, which means poking a hole in it, draining it, maybe cauterizing the base a little bit. But there is about an 80% recurrence rate of those endometriomas when they're just drained. So here's a very good visual representation of fulguration or destruction of endometriosis. We're basically taking off the stem, but we can see the roots are still there. There's more of a risk of that growing back quicker, whereas with excision, very awesome. Yes, there still might be a little bit of root left, for those who are there, sorry, but much slower regrowth of that tissue. Next, one big misunderstanding about endometriosis and surgery is that ovarian sparing, or what's also known as partial hysterectomies, they are not a cure for endometriosis. Let's go back to our earlier slides. Ovaries are what produce hormones, not the uterus. And so, as long as the ovaries are there, any small microscopic implants of endometriosis will eventually grow back. So again, hysterectomy does not cure endometriosis. What it does do is it does take away the pain associated with periods. It does take away the inflammation associated with periods. Now, when we remove the ovaries, whether it be with or without removing the uterus, that is most of the time, asterisks, read the dotted line, the small little underscored lines here, a definite treatment. But unfortunately, there is recurrence of endometriosis even after removing the ovaries in some patients. And why usually ovarian remnants or that variant type endometriosis tissue that can still be active even after menopause. What's horrible, there's some women who have been through menopause who still have endometriosis develop after menopause. But not common, but it is still a possibility. Then postoperative hormone replacement therapy, some data suggests that waiting or delaying that isn't necessarily a benefit, but there is always that concern if we're giving hormones, could that reactivate endometriosis? Definitely having some type of a progesterone can be beneficial for suppression there. All right, now this is my favorite part. So I'm extremely biased. Why? Because when you just do something, you learn to like it. Let me introduce you to the robot. This is the robot. We have this in an older version of it, but I love the robot. This is basically what a robotic surgery looks like, where we will initially start off with a laparoscopy. So I first start off with a standard laparoscope, get in and determine how many arms of this robot I'm going to need to use. So typically I just need 2 arms. Sometimes I need 3 arms to operate with. And the typical incision sites are shown here. So typically I have one in the belly button for the camera, one on each side for the robot, and then on the left side, I'd like to have an assistant to either retract or suction or remove the biopsies. And then that one on the right side, that red one, is for more severe cases of endometriosis. This is AI generated. They always make abs look amazing. Sorry, but it popped up in Adobe. I'm like, okay, fine. This is easier for me. I don't know. All right. So this is a picture of me and so prior to starting on the robot, and I'm so grateful for the amazing patients that have motivated me and helped me grow in this. When I was doing more of the fulgurative endometriosis, I felt I was getting pretty good, but then after meeting Dr. Duke and having a few patients who were having quick recurrence of their symptoms, I just felt like I wasn't providing good enough care, and so that really motivated me to do excisional endometriosis surgery with the laparoscope. And to understand standard laparoscopy, I can do this. So basically, I have straight instruments, and so difficult to reach areas are difficult to reach when you have that limited motion. But I still felt like Spider-Man. I felt pretty cool. My wife took this picture of me this morning in my pajamas. And so, but now with the robot, I feel like this. I feel pretty cool. I love it. And why is that? Because instead of this only motion, I have this motion with the robot, and it's amazing. I mean, there are days where I'm just like, I can't believe I just did that. This is an area that I previously would not feel comfortable operating in. I'm just going to send you to Dr. Duke or Dr. Arrington, but now it's just like, dude, that was easy. It's just amazing how easy it is now for this. And so I'm not saying you have to go to someone who does robotic excision, but my goodness, what it has accomplished for me, particularly, just is absolutely amazing. I want to show difference of images. So this is the standard laparoscope. This is a view of this patient's left pelvic side wall here with the standard laparoscope. And then here it is with the robot. Way clearer image, way easier ability to detect endometriosis implants I would not have received there. There was a smudge on the camera which made this look more like endometriosis right there, but there's one spot right there. Better easy identification of her ureter, and so again, it's just such clear imaging, so it definitely causes a bias here. Also, just the ability to just have easier grasp of this tissue. So with this patient, you're going to see highlighted in yellow her bladder, and then in red will be her endometriosis implant, and then this is just kind of a little standard. Let's get this endometriosis out so you can actually see what it looks like. So I'm going to grasp the tissue a little bit away from where the endometriosis spot is. Why? We want to make sure we get all of it. Going to make a small little snip there, get in, and then open and spread, and then there's a little simple technique to just get that peritoneum off of the structure that that endometriosis is on, and then just use some cut and cautery here to just get that spot off, and gonna just get the top part here, get that bottom part here pretty soon, and snip, and hey, let's get that bleeder, boop, done. And so, whereas historically it was just like, all right, it's so much more difficult. So just so awesome. Anyway, here's another part that's on the patient's right pelvic side wall. I'll point out a few things real quick. So this is the patient's ureter. You don't want to mess with ureters. You don't want to kink those off. You don't want to cauterize those. But this just shows again that. Come on, please work. Of course. Maybe this will work here. Cool. So this just shows that aspect of putting some tension on, and getting the planes, getting some of these blood vessels before they bleed, that neovascularization of certain areas there. You can see that ureter moving right there. Looks like a cool little worm underneath that peritoneum there. And just simple spread, and then get rid of it there. I don't show the whole video here, but just very easy to, manipulation of that tissue. Moving on, more to the summary now, and I'm just about finished here. So what is endometriosis? It is variant implants of endometrial-like tissue outside the uterus. Pain and inflammation disrupting their life. We're talking about pain with periods, chronic pelvic pain, pain with sexual intimacy and stimulation. That is, it is not normal to be in that much pain, to be that affected, to be that limited with your ability to function. That's not normal. The quantity, the size, the location do not necessarily equal the symptoms and severities of the patient. We definitely need to keep in mind the multidisciplinary approach involving other trusted colleagues in different fields, and I so appreciate all those that I regularly refer my patients to. Diagnosis is difficult. There's limited laboratory and imaging studies. Surgery is the only way to diagnose. We've reviewed some of the treatment options available, both hormonal and non-hormonal. I can't remember if I mentioned this, but oftentimes we think, well, this didn't work, so it's never going to work again. No, we do need to use all aspects of therapy, of treatment, of all aspects of, there we go, to help with their pain in different ways. And then with surgery, excision versus fulguration, again, I absolutely agree and favor excision. Endometriomas, those endometriosis implants need surgical excision. Partial ovary-sparing hysterectomies do not cure it. Menopause and hysterectomy with ovaries most commonly cures it, but I always caution how much it can affect someone who gets it too early in their life. General GYN versus specialist, or someone who subspecializes in it, there's a little more favorable outcomes with that. If you're seeing a specialist, whether they do robot or laparoscopy, I don't want that to defer you if they do robot versus that, but if they're a subspecialist, specialist in it, then whatever they're most comfort with, then absolutely. So definitely it depends on that skill set. These are some of the references for all the information here. And again, the link to that YouTube channel. And again, there's other QR codes for our endometriosis questionnaire as well too. And so that was the presentation. So I don't know if there's any questions or any questions that you guys have. Yeah.
Have you found a link between, excuse me, celiac disease and the endometriosis?
Yeah, so question was, have I found a link between celiac disease and endometriosis? 100% yes. So as for, can I say, here's this chemical that causes this chemical, I don't have that information, but I call it the female pelvic painful triad: endometriosis, irritable bowel diseases, syndromes, and interstitial cystitis. I very regularly see those together. They're all inflammatory diseases of the pelvis. And so oftentimes when I have a patient who's been treated for endometriosis or been treated for interstitial cystitis, painful bladder syndrome, I can treat those two things. If they still have persistence of pelvic pain or they don't see much improvement of their bowel symptoms, or even prior to surgery or treatment, I regularly refer to specialists in that field, whether it be gastroenterologists or general surgeons. And so I don't personally diagnose that, but yes, very commonly do I see those. And it kind of goes back to that analogy of driving on a trip with your kids. They can all be a little bit inflammatory at times, and so we definitely need to treat them all individually to hopefully have the car ride be tolerable. But yeah. Any other questions? Cool. Well, thank you all for coming out. It's so awesome for you guys to come out, and let's spread the word and help some people out here. So, all right, guys, have a good one.